reduced dose of Novavax, it shows that it is very effective against warfarin. And 1 year outcome also shows good improvement with rivaroxaban. So reducing the Novavax dose without an indication for dose reduction and against the label can increase the stroke rate without a benefit in reduction of major bleeds. That's very important. So whenever you should reduce it only when there is a definite need to reduce. So just giving a reduced dose thinking that it will avoid ischemic hemorrhagic episodes may compromise the ischemic benefit. As you see here, the utilization of Novavax against warfarin in non-valvular AF, which again, the meta-analysis of various trials show a 20% reduction in stroke, 50% reduction in intracranial hemorrhage, and 15% reduction in major bleeding, but 25% increase in GI bleeding. And not only when you use Novavax, especially rivaroxaban in patients with renal failure, there is preservation of renal function. And rivaroxaban is associated with lower adverse renal outcomes compared to warfarin. As you see here, Novavax are recommended in preference to VKAs. So that's the reason why Novavax are now recommended in preference to VKAs whenever chronic anticoagulation is indicated in atrial fibrillation. So these recommendations we have already discussed. As I said earlier, antiplatelet therapy alone is not recommended for stroke prevention in atrial fibrillation. And estimated bleeding risk should not itself guide treatment decisions to use OAC for stroke prevention, unless there is absolute contraindication for oral anticoagulation. And clinical patterns, whether first detected or paroxysmal or persistent or long-standing or permanent, should not condition the indication for thromboprophylaxis, because the risk for stroke is equal in all these subgroups. There is a first episode or paroxysmal or persistent or permanent. Now we come to the next group of patients with venous thromboembolism, the so-called venous protection. As you all know, oral anticoagulation is indicated in patients undergoing orthopedic surgery in knee and hip as a prevention for DVT and pulmonary embolism, plus also for treating DVT and pulmonary embolism. We have various studies which have shown their utility for treating venous thromboembolism. As you see here, they are as good as warfarin, and they have been shown to have a very good protective action. For dabigatran, rivaroxaban, apixaban, etoxaban, all of them show good preventive ability. Now, who is the challenging with venous thromboembolism patient? Now, fragile. 40%, 42% of patients with venous thromboembolism have a fragile constitution. And nearly 20% of them have active cancer. 20% of them have renal impairment. So, a creatinine increase of less than 50 ml, age above 70 years, body weight less than 50 kg, and very young patients, that is age between 10 to 24, they are all very high challenging cases. So as long-term anticoagulant therapy, Novavax is recommended over VKA for patients with VTE and no cancer. For VTE and cancer, the first option will be any drug which causes a low risk of bleeding and no drug-drug interaction, which includes rivaroxaban or edoxaban. So that is the approach for patients with venous thromboembolism and no cancer, and venous thromboembolism and cancer. Now let us look at the utility of rivaroxaban in the high-risk groups: fragile patients, cancer patients, young age patients, renally impaired patients. In all these patients, as you see here, rivaroxaban gives satisfying results compared to the controls. Rivaroxaban has consistent safety results also. All these fragile cancer patients, young patients, and renal impaired patients. So thereby showing it reduces the risk and also has a safety margin. So in venous thromboembolism, rivaroxaban has been studied in a wide spectrum of challenging cases: fragile patients, renally impaired patients, patients with active cancer, and patients with a young age of less than 18. So we have a relative risk reduction of 73% whenever rivaroxaban has been used in patients with DVT bar pulmonary embolism versus enoxaparin. And in patients with recurrent venous thromboembolism, frail patients fared better than enoxaparin. So rivaroxaban for DVT, you give 15 milligram twice a day, the total dose of 30 milligram for 21 days, followed by 20 milligram OD or 10 milligram OD, depending upon whether you have to give a low dose or not. Summarize. Last 20 years, we have seen a good number of new or novel oral anticoagulants. And they have really revolutionized the treatment of chronic anticoagulation. The oxabans are factor Xa inhibitors, whereas dabigatran is a direct thrombin inhibitor. Rivaroxaban and apixaban have a low renal clearance. And rivaroxaban is the only NOAC to be approved for secondary prevention of acute coronary syndrome, chronic coronary artery disease, and chronic peripheral arterial disease. And rivaroxaban is the only NOAC to be used, which has specific renal dose response, is even in patients up to 15, specifically up to 15 ml, creatinine less of 15 ml per minute, where you can use a dose of rivaroxaban 15 milligram once a day. And when used in patients with renal disease, there is evidence for preservation of renal function with rivaroxaban versus warfarin, and it has been incorporated in the guidelines. And the greatest advantage of rivaroxaban is that as a single drug approach in DVT treatment, doesn't require any initial warfare, initial heparin therapy to be followed up with oral anticoagulation. So it's a single drug approach. So straight from the day one, you can treat them with rivaroxaban. Similar thing is also with apixaban. So dear friends, I have talked to you about the utility of rivaroxaban under various situations. Most important is acute and chronic ischemic syndromes, peripheral vascular disease, then the group of non-valvular AF, and then patients with renal impairment who also require oral anticoagulation because of AF and other indications, and then venous thromboembolism, including pulmonary embolism. Thank you.
Thank you, sir. Thank you, sir. Sir, we have received 2 questions, sir. Sir, my
Yes.
voice is audible? Yes, sir. Sir, comparison of
absolutely.
yes, sir. Comparison of bleeding between dual antiplatelet therapy and low dose of rivaroxaban, sir. Sir, my voice is audible, sir. Ritesh, sir?
Yeah, I think sir has got some connection issue. So Muthiah sir, you can switch on your camera also. Yeah, you can just switch on your camera also. Yeah.
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
Right. So I think sir is having some technical glitch.
We have to wait, sir.
Yeah. We'll just wait a couple of minutes. I think sir is logged out, so he'll just be coming and. Muthiah ji, I just received a call from sir. He might not be joining us again. I think there's some network error at his end. So you can conclude the session. Yeah.
Sir, please unmute yourself.
So, my voice is audible, sir?
Yeah, now it is
Yes,
audible.
Yes, sir. Yes, sir. So, it is my immense pleasure to thank one and all who are gathered here. My sincere thanks to Dr. S. Natarajan, sir. He is a senior consultant and professor for interventional cardiologist at GKNM, Coimbatore. Thanks for wonderful speech. And thank to all delegates to giving your valuable time to on Sunday. Hopefully you are enjoyed. Thank you. Thank you.
Thank you so much. Thank you.
Thank you, sir.